Well, hello and welcome to episode 4 of the Dr Syl Podcast. Today, I'm very excited to announce that we're going to be interviewing Professor Paul Fitzgerald. Professor Paul Fitzgerald is a professor in psychiatry. He's worked at multiple universities, including Monash University and ANU, the Australian National University. He's also working as a psychiatrist and involved in a significant amount of research where much of the focus of the research is around TMS, Transcranial Magnetic Stimulation, which is a very promising and exciting therapy that has a strong evidence base already to treat treatment-resistant depression. He's been instrumental in making it Medicare funded, and in this conversation we talk about depression, we talk about treatments for depression and why they're insufficient, how TMS fits into the treatment kind of milieu, and we talk a bit about what it's like to have TMS as a patient. The conversation we have takes lots of interesting tangents into my curiosities, and I was just absolutely amazed at how Paul had all these wonderfully insightful answers to the quirkiest questions that I could come up with. Paul has really been at the forefront of the development of TMS in Australia for the past 20 years, and I can't wait for you guys to have a listen to this conversation. I hope you enjoy it as much as I enjoyed hosting it. But before we get into it, a quick disclaimer. This podcast and this conversation is completed in a personal capacity. I am not representing any medical college or workplace, and all the advice that Paul and myself discuss in the podcast, it's general advice only. This is not personalized, targeted medical advice. And if anything we talked about made you think about maybe if TMS is right for you, then the best course of action is to talk to your general practitioner. But with that disclaimer out of the way, let's get into today's discussion. Paul, thank you so much for joining us on the podcast today. It's been something I've really been looking forward to, and I've thought a lot about TMS over the past month while we've been playing it. And I've been thinking a lot about depression, and it's a really complex disease, illness, and there's definitely a lot of opportunities for improvement in the treatment options available. So I was wondering if maybe a nice place to start is for you to tell me about your journey into psychiatry and then this focus you have into depressive treatments.
Well, look, thank you for the opportunity. My journey into psychiatry was a relatively accidental one. I had pretty dreadful experiences in terms of exposure to psychiatry during medical school. Didn't really have any intention of going in that direction, but really found there was a degree of lack of humanity in some ways in the way that patients were treated in the general medical system, particularly in a large tertiary teaching hospital, in the sort of silos between specialties. And I thought psychiatry might be an area of medicine that allowed for a little bit of a more holistic way of thinking about people and their experiences. And so gave it a go and really found it very satisfying. By the time I finished my training in psychiatry, I again was a little bit unclear the direction I wanted to go. I'd had some exposure to research, was interested in research, but not sure that was what I wanted to do with really serious intent. So I was very fortunate to be able to arrange a fellowship in Canada where I was able to spend half my time doing research, half my time doing clinical work, and got exposed to some really amazing researchers who thought very deeply about what they were doing. And it was very clinically oriented research, sitting down, analysing the latest paper and thinking about what that meant for their treatment on a day-to-day basis. And so got really inspired by that and, had my first exposure to, a lot of the technologies that we use, neuroimaging, TMS, etc. And so came back very much with a commitment to try to find a way to be able to do both, to continue to do clinical work and do research.
I wonder what that's like to be involved in kind of not only the advancing of human intellect and knowledge, but using that, being on the front line of that in the treatment of real patients and people that you treat. What's that like for you?
Look, it is really fascinating. I had an experience of, during that fellowship, there was a very live debate about a fundamental theoretical aspect about how certain types of medications used in schizophrenia work. And even within the institution, there was between two very prominent people this kind of, very diverse opinion. And we scanned one of my patients and kind of for the first time realised an aspect of how these medications work, which resolved that debate. But it was just sort of fascinating to be right at the forefront of that, and for a relatively short period of time, be in a very small group of people who knew something that the rest of the world yet didn't know. And that is really fascinating. And you have that experience really every time you finish a research study. There is a point at which you analyse a set of data, and you look at it, and you've learnt something. It may be a positive result, it may be a negative result, it may not be very profound. It might just be some small accumulation of knowledge. But there's a very short period of time when, if you've done the analysis, you're the only person who knows that information, and that's quite a privileged position to be in many ways. And it's often quite, gives you pause for thought.
Yeah, I was reflecting last night with some friends about the importance of science communication, podcasts and publishing research, and not only publishing research, but doing it in a way that's understandable. And we were just reflecting on how many interesting insights that exist that no one knows about because they haven't been communicated widely. And that made me think a lot about how important it is to communicate effectively. So thanks for hopping on a podcast to help us spread the good word. In this podcast, we wanted to talk a little bit about depression, how you see it, and how you see, what is TMS and how it fits in the treatment of depression. I guess as a quick rundown, maybe we can start about, how do you think of depression as an illness?
Yeah, so I certainly don't really think about it in the traditional ways as a neurochemical disorder. We clearly know that depression's not a thing caused by not having enough serotonin in your brain. That's, a myth that's been propagated for many decades. The way I see depression is that it's a complex disorder of the way in which areas of the brain communicate with one another. That's created through a whole series of complex interactions between life events and genetics and the way we are raised and the experiences we have that we're young. And then in some ways, the experience of depression is almost a final common pathway. There's, a myriad of ways of getting there, but there are some similarities although obviously differences as well, in the ways that people with depression experience their symptoms. And that is probably because through those variety of pathways, there ultimately is a set of disruptions that get embedded in brain function. And that's around some areas of the brain that are overactive, other areas of the brain that are underactive. But particularly, rather than thinking about in terms of specific areas of the brain, I'd talk about in terms of networks, so that the networks that underpin, for example, the way we reflect on ourselves and our internal thoughts, those networks, for example, tend to be overactive, and that tends to be really strongly associated with the fact that people with depression will spend a lot of time in their own head, thinking very negative thoughts and ruminating and so forth. And there's really a failure to switch off those sorts of networks when somebody needs to concentrate and do something in an effortful way. So something's happened to disrupt the balance between the different sorts of networks in the brain.
And it's interesting to think that way, because it's really addressing the fact that our experiences influence our biology, and our early childhood experiences and genetics, of course, influence how neurons physically behave. And that leads into treatments that are of a physical nature. So, we've spoken about in registrar teaching the mechanism of medications, but also the direct action of different, neurostimulation technologies. So what is TMS and how is it fitting in all this?
Yeah, so TMS, or transcranial magnetic stimulation, is very simply put, it's just a way of trying to modify brain activity. With medications, we do it some ways in a very subtle way, because the medications that we use for things like depression tend to sort of just modulate the way nerve cells fire around the brain. A TMS machine produces a very focused but very strong magnetic field that's able, similar strength magnetic field that you might have in an MRI scanner, but it's only applied to a very small area of the brain, 1 or 2 square centimetres. and it's of sufficient strength, and when it's switched on and off, to actually make nerve cells fire. So we can make a big bunch of nerve cells in a specific region of the brain fire, and over time, if you repeatedly stimulate nerve cells, you'll make them more or less active, depending on the way you do it. But more importantly, you will also activate a whole network, because those nerve cells project to other parts of the brain, and then they'll stimulate other nerve cells, and you'll so change network activity, or change potentially the strength of connections between brain regions. And so when we think about that in the context of depression, the challenge is to say, well, what are the areas or the critical hubs or nodes or networks involved in depression, and how do we target those in a way that we can change their activity that in a way that's going to have therapeutic intent? And so the most common paradigm that's used in depression targets an area at the left frontal part of the brain at a frequency that's designed to strengthen those areas of the brain or those connections that are involved in more the thinking parts of the depression circuitry, to sort of switch back on some of the areas of the brain that control behaviour, that control our capacity to concentrate and think and so forth. And perhaps to regulate other areas of the brain to help switch off those areas that are overactive, associated with the negative emotions and so forth. And that takes time, and it takes appropriate targeting, and people have treatments recurrently over the course of usually many weeks. But we know now very convincingly that done appropriately, it will help a significant proportion of patients with depression.
I'm curious to find out how we found these nodes. I know it's the kind of dorsolateral prefrontal cortex, and usually the left for hyperstimulation, and there's other ways to address the right one. But was that trial and error? Was that in animal models? Did you find that when we stimulated part A, things got worse, and part B, things got better? Yeah, how did we discover that?
So TMS in depression is one of the few things in psychiatry that wasn't a completely incidental finding. The vast majority of the medications we use, etc., have all come about rather incidentally. But there was some science or some scientific thinking behind the way it was developed, although some of the assumptions in that wouldn't necessarily hold up now. So in the early to mid 1990s, the first brain imaging studies that were really being done in depression using positron emission tomography, which looks at the sort of metabolism of brain areas, was starting to show that this left dorsolateral prefrontal cortical area of the brain was underactive in people who were depressed, particularly if they were just lying in a scanner at rest. And the early studies demonstrating the effects of TMS showed that, particularly if TMS was applied at high frequency, you could increase brain activity. So it was a bit of a 2+2 scenario. We've got an underactive brain area. We've got something that might change that. Let's apply one to the other and see if it works. And the first studies that were done were very short. They were, relatively speaking to what we do now, quite low dose, because there were lots of concerns about a new technology being applied to the brain and its safety. But they were sufficient to demonstrate some therapeutic benefits.
Wow. And
that sort of really was the trigger for everything that's happened since then.
Mm. So my brain's going to why, and this is probably a very hard question to answer, but why are medications insufficient? Why can't SSRIs increase the activities of these areas, and why do we need to go to these kind of neurostimulation technologies?
I think the simplest way I would answer that is to say, although it was proposed that it was a case for a very long period of time, these medications aren't fixing a deficit. It's not that, when somebody takes a medication that increases the neurotransmitter, neurochemical serotonin in the brain, it's not that they had a deficit of that in the first place. So effectively, we're creating an unusual or an abnormal state of excessive serotonin that might trigger something in the brain that has therapeutic benefits, but it clearly may not. And the neurons that use serotonin in the brain are pretty widely distributed. They're a relatively small proportion of the brain cells, and they come from a very small area deep in the brain, but they can influence a wide range of brain activities. But they're modulating, they're tuning things up and down. And it may well just be that either that's just not sufficient with individual patients, or that some patients, the fundamental underlying networks are just not regulated by serotonin in the way that they are in other patients. I think we assume incorrectly probably that depression's a relatively homogenous sort of thing, and I think that's not the case. And so if there are subtle differences in the networks involved, it may be that serotonin or noradrenaline, one of the other chemicals, are just not involved adequately in regulating those, or that the perturbation, the change in the system that these medications produce, doesn't have that desired effect. So we do definitively need a variety of other options.
Yeah, I often think about these illnesses I think it's really important to think of them as heterogeneous groups of different disorders that we don't have the exact cause knowledge for, and that there's probably type 1, type 2, type 3 depressions, the same way that there is with diabetes, and maybe a type 1 depression is influenced by serotonin, the serotonergic milieu of the neurons. But maybe type 2 needs more therapy, and type 3 is maybe more neurostimulatory. So I think a lot of people can imagine what it's like to take a medication and have side effects, but not many patients might have an idea of the patient journey in receiving TMS and what it's like. I was wondering if you could put, me in the place of a patient and what to expect if I arrive at a clinic one day and receive a TMS treatment, what that's like.
So there is initially a slightly odd procedure that's done to help work out the sort of dose of how the treatment's done. So the TMS machine, which is essentially a coil that is small enough to be handheld or sit on the head in a stand, is placed over the area of the brain that controls the muscles in one of the hands. And the machine is essentially turned up slowly to the point where it makes the nerve cells in that area of the brain fire to send a message down to cause a muscle twitch, which kind of feels a bit odd. You've got this thing which you feel as almost a tapping sensation on your head, and then your hand starts twitching, and you can't stop that. It's involuntary. So that procedure's done first. It's a 10, 15-minute procedure, and then the person will go ahead with their treatment. The coil is placed in a stand across the more frontal parts of the brain. The person usually is in a reclining chair and is asked just to relax. They can close their eyes, listen to music.
Just can have earphones in, listen to music.
Yeah.
Oh, nice.
And the sensation is, it really varies. A lot of people, and it varies based on how high the machine needs to be turned up for an individual patient, and that tends to be more dependent on things like just how thick your skull is and how much fluid there is between your skull and your brain, because the magnetic field falls off relatively rapidly with distance. So the further it has to go, the higher it has to be turned up. The sensation is generated through stimulating the nerves and muscles in your scalp. It's not anything, you don't feel anything in your brain. And that sensation is, might feel a bit like a sort of, it's been described by many patients to me like a tiny Lilliputian man with a little jackhammer sort of tapping away on your head. And for most people, it's pretty benign. It doesn't bother them, or they get used to it quite quickly. Somewhere between 1 or 2 and 5% of people find it quite uncomfortable and it does take some getting used to, because it might just be over a nerve, or it has to be turned up pretty high for them. And with the older fashioned protocols that used to go a lot longer, sort of 5% of people would end up feeling a bit sort of headachy afterwards, or those sorts of things. Having said that, it's pretty rare that a patient can't go through with a course of treatment. Some people can't, like all treatments. But whereas if I start somebody on a new antidepressant medication, probably somewhere between 15 and 20% of people are likely to not tolerate that medication. The number with TMS is in the very small single-digit figures. We know from research there's one study looked at 95 clinical trials, and the dropout rates for people having real treatment were no different than the dropout rates for having placebo, and they were less than 3%. So it's it's very well tolerated in most people.
How do they, just out of curiosity, how do they do the placebo for it? Is it literally just a noise and a tapping machine, or?
Yeah, so a variety of different ways. Sometimes we angle the coil so it produces some scalp sensation and the noise. There are other systems where the coil is sort of held off the head, and little electrical stimulator electrodes are used to again produce the sensation and the noise. So there's a variety of ways it's done.
I'm curious to think about how this is. So we're talking about depression as a single disorder a little bit, but obviously it's often comorbid with other illnesses. Have you found any characteristics of depressions or a depression with personality disorders or substance use, has there been a kind of patient profile that typically benefits the most from this kind of treatment?
Yeah. So we've done a lot of work in very large samples, over the years trying to look at clinical characteristics. And there isn't really anything that's a strong predictor. We certainly see very good response rates, even in patients who've got comorbidities with other anxiety disorders, PTSD, etc. Having said that, like every psychiatric treatment, the more complicated the patient, I think there is some mitigation of effects. So, if a patient's got chronic pain or a comorbid eating disorder or a comorbid personality disorder, they are probably less likely to respond. But that doesn't mean they're not likely to respond. And I've seen patients over the years where I might go into a course of treatment feeling, not quite sure that, that this is going to be successful, and then get pleasantly surprised. And it's very important, I think, not to be sort of therapeutically nihilistic, because that just isn't often the case. I remember many, many years ago, it would be probably close to 20 years ago now, seeing a patient who had what appeared to be a very severe comorbid borderline personality disorder. And I just really felt that this treatment was, probably going to be of limited effectiveness. But I thought, the patient had been referred by a psychiatrist I knew very well, I respected. So I thought, well, obviously he feels that there's a chance that maybe the TMS can help the patient's mood, and that might enable her to engage better in therapy. And she had a dramatic and, in many ways, quite miraculous response. And over the course of the next 2 years, while she continued to have some maintenance TMS, she was able to get back the care of her 2 children that had been taken off her. She re-qualified in her profession and started work again, and was really, really able to completely rebuild her life. It didn't mean that there wasn't still, trauma and other things that she dealt with, but it changed her life and allowed her then to not just get on with her life, but also to kind of get on with therapy in a way that would ultimately have, very long-lasting benefits. And so I certainly learnt then that that yes, there are clinical characteristics that may or may not predict response to treatment, but unless they're clinical characteristics that are going to say you've got a 0% chance, or that are going to say there is another treatment that is a lot better, then you have to be kind of wary. And most of the patients we are seeing are coming because other things aren't working anyway. And so it's pretty infrequent, or very infrequent, that I would be saying to somebody, look, you really don't want to try this, because for most patients there is at least a reasonable likelihood that it will work.
Is there any absolute contraindications to getting TMS, like if there's a brain tumor or anything?
So what we would regard as an absolute contraindication has shrunk over time. So, the one serious side effect of TMS is there's a chance it could trigger a seizure, like someone with epilepsy would have. Now, fortunately, it's really rare. And, over 20 years of doing TMS, I've not had a patient that I've treated experience a seizure, in many thousands of patients. And we have got to the stage where, under very careful circumstances, with very clearly defined informed consent and so forth, we've treated patients with epilepsy. And they've had successful responses to treatment. I think, other than a cochlear implant where there's a really significant danger of, or other metal electrodes in the brain that are made of materials that could be influenced by the magnetic field, or a very active brain disease that you're not really confident about what the effects are. There are other contraindications, but most of them I would regard as relative. Again, having a pacemaker was regarded as an absolute contraindication because the magnetic field could interfere with the pacemaker. It's pretty clear now that the TMS coil is far enough away from the pacemaker that that's just not an issue. You have to, be 100% sure that there's no way the coil's going to slip and end up down near the chest, but we've gradually expanded into some of these areas that we used to be much more concerned about.
So you've been at the forefront of this really revolutionary treatment. You know, it's really helping a lot of people who have failed multiple other therapies. What's it like to? I mean, like you must want it everywhere and feel like it needs to be much more popular in all the cities, but it's probably being underused. Is that fair to say? And so, is it being underused? And where do you see it in 10 years? Do you think it's going to explode and that every major city will have a treatment centre?
So, look, absolutely. The first thing you said about wanting to have treatment available to more people, as we do research, I'm extremely focused on, we want to do research in a way that ultimately leads to translation and helping people. And I spent many years, it was a journey of probably 8 or 9 years of learning that ultimately led to us getting a Medicare item number to support the use of TMS treatment. It was one of the more painful and challenging.
It sounds very hard to do.
Things to do, but and as it turned out, that has opened the door to many, many patients having access to treatment. Although because of the characteristics of the way the item numbers are structured, it is still fairly restricted. But we started off many, many years ago setting up TMS programs in private hospitals around the country, because that was one way that patients could get access to treatment. You don't need to be in a hospital to have TMS treatment, but it was a way to get access to patients. And so that was kind of a compromise. And then we tried to work in parallel on getting the item number. We set up outpatient-based clinics around the country. So we've done a lot of work to try to get, and including outpatient-based treatments in sort of, outer suburban and some rural areas, so that, access would increase. But it still is something that I still, even though now TMS is very much more widely used, and in some places even more so. I was in China a couple of months ago, and I heard from a very senior psychiatrist there that they estimate about 20 million patients in China are having TMS every year now. It still could be more widely used, and I think psychiatry is a relatively conservative profession, and a lot of psychiatrists still, see their practice as being focused on the things that they've always done, be that psychotherapy or be that medication. And I still think there is a need for the word to spread more. We had a very unfortunate situation a few years ago where the college clinical practice guidelines that describe how TMS should be treated, should be used in treatment, were revised. The earlier guidelines clearly outlined quite correctly where TMS should be in the suite of treatments. The college guidelines were developed in a way that really sidelined TMS, and when the section in the college who have responsibility for these sorts of treatments provided feedback and said, look, this has not been written in the right way, for some reason that was ignored, and the guidelines were published in a way that was very misleading. Now, there were other problems with those guidelines that have been addressed by the college more recently in terms of recommendations about particular types of psychotherapy, but those issues around TMS have not been adequately corrected, and that still stands as a public document, endorsed by the college in a really unfortunate way. It's certainly out of kilter now with really the stance of professional societies all around the world and all of the experts, and so and I think that does just reflect that sort of conservative nature of the profession, that there were individuals who were wanting to push back against something that was new and innovative and perhaps not consistent with the way they saw the way psychiatry should be, which is sad in a way, because ultimately it has a deleterious impact on our patients.
Why do you think it's, well, maybe I hope I'm not putting words in your mouth, but why do you think it's so common that we're such a conservative profession?
Look, I think across most areas in general, but certainly in psychiatry and medicine, you have early adopters, people who'll see a new treatment and want to get involved very early, and then you have a very long tail of kind of resistance. And I think there are some people who go into psychiatry because they are interested in the very sort of therapeutic end of the spectrum, and that's perfectly fine. There's psychiatrists who do fantastic work as working with very, very traumatized and challenged people, but aren't necessarily kind of open to a broader range of treatments. And again, I think there are other psychiatrists who work with medication, for example, who might just not be open to considering where new treatments fit into their practice, because that's what they've always done. It might be for many, many years. There are lots of psychiatrists, and I definitively believe this, who just want to do the right thing for their patients. But we all have our own biases, and we all have our own ways of seeing the world. And I think when something like what I described before happens, when the college comes out with a document that unfortunately was just very poorly written and incorrect in the way it represented a treatment, that is then going to influence your psychiatrist who's out there working in clinical practice. They don't have time to go out and reread all the literature and analyse this. They're going to accept that this is a document being produced by so-called experts, and that's going to have an undue influence on how they think about something like TMS treatment.
So as you've been saying, TMS has now been around for more than 10 years, almost 20 years. I was hoping you could talk to us a bit about some longitudinal data to see how the effectiveness of TMS is holding up over time.
So what we clearly know is that initial response and remission rates are very good with TMS. Certainly, and there's some comparative data coming out now that if you look at a patient coming along who's had 2, 3, 4 medications and are offered a course of TMS or another course of medication, that they're more likely to respond to the TMS. We do have realistically less long-term data. In many, many years of experience, the way I kind of see it is that there's a subset of patients, maybe it's 20 or 30%, whose benefit from TMS is relatively short-lived. And I think in the long term, and we can come back and talk about it, those patients are ultimately likely to benefit from some sort of what we call maintenance treatment, so ongoing treatment with TMS. There's patients who get better with TMS, and essentially I just think then their illness follows the course it would take otherwise, whether they're depression for the vast majority of people is a relapsing condition. So it's likely to come back at some stage, but that could be 2 years down the track, 5 years down the track. And I've had patients come back after 5 years and say, I need another course of treatment because my depression's coming back. And there's a lot of patients who are in between, where it might be they need some sort of top up or extra treatment every 12 months or every 18 months. So it's a real spread. What we know is if somebody's depression comes back again and they have another course of TMS treatment, the likelihood it will work for the second time and the third time and the fourth time is very, very high. And I've seen patients who've had yearly treatment for over a decade, and every time almost respond in an identical way. They'll have a very stereotypical response each time around. And that's pretty predictable. Not many patients, some do, but not many patients will kind of fall out of responding as they go along down the line. Now that can be that. I'm not saying that's perfect, because it's kind of inconvenient to have to go back into a clinic and have treatment, say every 12 months or so forth. But it's certainly a better option than what these patients might have otherwise if there's nothing else that's worked for them.
Yeah, it's interesting to think that it doesn't desensitize the brain to a response in the future. I often think about the treatments for depression as helping your neurons modulate to more adaptive processes or respond to better behaviors. So, it's producing BDNF alpha, a lot of the treatments. Is that right? Yeah, brain-derived neurotrophic factor. And so neurons are more ready to adapt to better behaviors. And so if you start exercising, if you start connecting with friends again, if you start eating well, then the depression symptoms should improve, and they should improve more if you're in a state where you can have neurons more responsive to those changes. I'm wondering if TMS is still effective if people don't change other parts of their life. It's probably a hard study to do, but maybe from your clinical experience, have you seen that TMS helps people kind of get back on track and maintain that positive response? Or if people kind of don't change other parts of their life and just kind of do TMS for the depression, is it less effective?
So I think in the short term, the answer is in some ways, not it doesn't matter, but absolutely yes, it can work. And I think the exemplar of this is we see many, many patients who will come along for a course of treatment, and because of their depression, they're just extremely pessimistic and having negative thoughts, and they don't believe treatment's going to work, and they're not engaging in things to change their behaviour because they're very profoundly depressed. That is just the nature of the condition. And some of those patients get better, and they'll often be very pleasantly surprised. I've had a patient I treated for probably 15 years and had many, many courses of TMS over that time. And every single time she would become depressed, the first conversation she would have would be, "This is not going to work for me, is it, Doc? You're going to sack me as a patient because this is not going to work and I'm depressed again." And every time she would respond, usually after about 2 weeks of treatment, and go back into remission and then go and get on with her life. I think where it matters more is not during that acute period of time when someone's depressed and they may not be able to do the things we're talking about. If you're profoundly depressed, you're not going to get out of bed and go and exercise, and you can't meditate because you can't concentrate. What matters, I think, more is those things in the long term. When a patient recovers, the more that they can do to, build positive social networks, exercise, do mindfulness. And I think mindfulness is something that doesn't really work when you are depressed, but does definitively work at helping reduce the likelihood of your depression coming back. I think all of those sorts of things, eating well, all of the sorts of things that we would traditionally regard as being good for your well-being are going to reduce the likelihood of your depression coming back. It doesn't mean it's going to stop depression coming back in everybody. I think, unfortunately, it doesn't matter what some people do, it will come back. But it's all about odds. It's about likelihoods. It might get you another 3 months before it comes back, or it might reduce your chances of depression coming back by 10 or 20%. It's certainly worth doing, but that's more the long term rather than the short term.
So if I was going to get some TMS, what would be the kind of out-of-pocket expenses for me? I'm just realizing I have no kind of concept of what the cost is from a patient's perspective.
So it really depends where and how you have treatment. So as things currently stand now in Australia, Medicare will subsidise an initial course of treatment, and there are clinics that will bulk bill, even though the Medicare rates now, as with most Medicare funding, aren't really keeping track with the cost of providing treatment. So it'll either be potentially free initially, or some relatively modest additional cost. The problem with the Medicare funding and the way it's currently structured is Medicare provides a decent initial course of treatment, so up to 35 treatments, which is very good. And there is the possibility, if you respond to that, to come back and have one set of additional treatments. But there are really two problems. One, that additional set of treatments is limited to only 15 treatments. And then after that, Medicare won't subsidise any further treatments. Now, both of those things are quite bizarre in some ways, and I don't really understand the rationale of how they did this. So Medicare, so when we talk about the initial extra set of treatments, the 15, Medicare looked at the data that had patients who'd had an initial course of treatment and then came back and had a second course of treatment. And these were patients generally in research studies, so they were being monitored very carefully. And so when they came back with their depression coming back, that was picked up very quickly. And so they needed less treatment than somebody in the real world might need who's, been getting on with their life, and then their depression comes back and they need a further course of treatment. But an even bigger error was that they looked at how many treatments those people needed, which was probably artificially low because they were picked up early. And they said the average was 15. Now, an average means there were some people who needed less, but there was also a whole lot of people who needed more. There might have been some who needed 20 and some who needed 10, and they ended up with 15. So by choosing an average, you're under-treating all of the people who sit above that average level.
50% of the people.
And that's just doesn't make sense for me. They then said, after that second course of treatment, we're not going to fund if your depression comes back in 2 years' time, we're not going to fund that at all. And that, to my mind, is in many ways is just a financial distinction which is quite discriminatory. There's no really other areas in medicine where we make those limits. And certainly no areas in psychiatry. If you are referred to a psychologist for Medicare-funded psychotherapy, you can have your sessions this year, and you can come back and you can have those sessions next year. You can have unlimited Medicare-supported courses of electroconvulsive therapy. You could go and have an arthroscope on your knee every year for the rest of your life. And so that's kind of quite discriminatory as well. And then the final thing that they did really badly, I think, was that they said, if you've had TMS before, you're not allowed to have Medicare-funded treatment. So if I've gone and paid thousands of dollars for my own course of treatment, I'm now not allowed to have Medicare-funded treatment. And even a greater problem is that there are, and there have been, many, many thousands of patients around the country having TMS as an inpatient in private hospitals at very considerable cost to the healthcare system. I estimated at one stage when we first applied for Medicare funding that the health system was probably spending somewhere between $50 and $70 million a year for inpatient TMS, the vast majority of which was not necessary. You know, some patients need to be in hospital, but the majority didn't. They were just going into hospital to have TMS. And because Medicare made this restriction that if you'd had previous TMS, you couldn't have Medicare-funded treatment, instead of allowing those patients to have their future treatment courses outside of hospital and saving all of that money, those patients are not able to access Medicare-funded treatment, so they're going to keep going back to have hospital-based treatment, or they're not going to be able to access treatment at all, which is really, really unfortunate.
And I'm wondering if there's, that calls for quite a simple admission from a private hospital's perspective to have someone just come in for TMS, have plenty of leave, and it's very expensive, but maybe not exactly necessary or what's best for the patient. So that's an interesting thing. There's some big call to actions in this discussion, right? There's the college who I guess we're requesting to have a review of the guidelines and how they portray TMS. And then there's Medicare, and we're making a big ask around having them review their funding. Yeah. So I just wanted to clarify, if I'm going in privately and I can't pay from, like I don't get any Medicare subsidy, for one treatment, what is the typical cost that I'd be out of pocket for?
Yeah, so most clinics charge somewhere between about $180 or $200, maybe $220 per treatment. And you're looking at a treatment course that's going to be somewhere between sort of 20 and 30, maybe up to 35 treatments. So it's certainly not cheap if you're paying that straight out of pocket. I would say to the majority of patients, if you're going to commence a course of treatment, you should be at least accepting you're going to have 20 minimum of 20 treatments. If you get to 20 treatments, you'll have a pretty good idea if it's working or not. There is a chance that if it's not working at 20, it still might kick in after 25 or 30, but it's less likely to do so. But anything less than 20 would be, I would say, really an inadequate course to have a sense of whether it's going to work or not.
And am I coming every day? Am I coming 3 times a week? It's a lot of treatments. How often do I have to get them?
So standard treatment is done 5 days a week. It doesn't seem to matter if you miss a few treatments here or there and it gets a little bit more spread out. But we would typically want patients to follow as close to that as possible. We are now doing, and other groups around the world are doing, a lot of research on what we call accelerator or intensive approaches to treatment, which are designed to try to shorten that duration and make treatment more efficient, both with the intent to make it more convenient for patients and also to try to make response to treatment more rapid, so that it potentially could be something that's used in more sort of very acute or emergency situations. And a lot of that research is really super promising. It's probably not quite yet ready for sort of mainstream clinical use, but it's certainly getting to the point where some clinics in Australia will provide forms of accelerated treatment. Say, for example, for a patient who lives in a country area and might come down and stay in the city for a week or two, or just has other problems with accessing treatment on a longer term basis. So that's certainly something that's promising, but still needs a little bit more work on.
My brain's going to how TMS would fit in with other treatments at the same time, and imagining someone doing TMS and psychotherapy and on an antidepressant, and like all these things happening in the brain. And I realized we haven't really covered if there's evidence around and what your intuition is around whether multimodal approaches to treating depression, like TMS plus psychotherapy plus antidepressants, significantly better than doing one or another. And then I'm curious to talk a little bit about TMS and meditation, if there's been any looking into that. But yeah, what can you tell me about multimodal treatments with TMS?
So starting with medication, there's studies that show that TMS works whether you're taking antidepressant medication or you're not taking antidepressant medication. So if you start on a new antidepressant medication and you start TMS, you're better off having the TMS than not. It's going to be better than just having medication alone. The reality is most patients having TMS, medication hasn't really worked anyway. And so often or it's only worked partially. It's a very common scenario that we'll see a patient who's the medication's kind of taking the edge off. They're no longer suicidal, but they're still miserable and unable to get on with their life. So I don't think there's a lot of evidence that it's a really kind of synergistic effect. It's just that one can work the TMS can work in the context of someone who's had a partial benefit. I tend to be of the opinion when it comes to psychological treatments that a significant proportion of patients with TMS would benefit from engaging in some form of psychological treatment, either during or perhaps more towards the end and then after their treatment. We've tried for many years to get research funding to support studies in this area. It's been one of the hardest things to get funding for. So I wrote a grant that sort of was to do concurrent mindfulness-based cognitive therapy with TMS. And the reviewers all pretty much said, look, don't do it at the same time. Do the TMS first and then the therapy afterwards. And so we rewrote the grant to propose that. And then the reviews came back and said, you should do it all at the same time. And just this frustrating cycle
Another call to action
of going around. I kind of think that, there are some patients will, other patients won't be able to engage in therapy whilst they're having treatment just because they're so depressed. But starting to build a relationship, starting to prepare patients for what they need to do as they recover is a really sensible sort of thing. And I would include sort of mindfulness and meditation in that as part of that. I think, one of the things that has the greatest evidence for preventing depressive relapse is mindfulness-based cognitive therapy. And so sort of starting to prepare for that while somebody's having their treatment such that they can really start to engage in that more intensively once the treatment's finished, I think is a really sensible sort of way to go about just approaching embedding TMS in clinical practice.
I just had while you're saying that, realization that TMS is this external modality of affecting neuronal change for positive outcomes, and psychotherapy and meditation are these internal modalities that we have. So combining an external and internal modality of, remapping neurons into more healthier networks makes a lot of sense, intuitively at least. And I guess a nice place to kind of close off this incredible conversation. And by the way, I've got to say, I'm just amazed that you have such insightful responses to every question that I can shoot at you.
Thank you.
I've been trying to ask some left of field ones, and it's just been so helpful for me to understand. But I'm wondering if there's a psychiatrist watching this, and they're listening and they're thinking, I think it's time for me to get involved in TMS. Because I think there's probably a lot of psychiatrists who are really interested, but don't really know where the next step is and how to make it part of their practice. What's your advice? Talk to me as if I'm a new psychiatrist, hopefully one day, and I want to start getting involved in my private practice or maybe public practice to start incorporating TMS.
Yeah, so I think ultimately at some point in time there's going to be a decision around how intensively do you want to be involved? It might just be around becoming sufficiently educated so you feel confident about what are the patients you should refer to TMS. And in many ways, I would say any psychiatrist working in general psychiatric practice now should have that knowledge. TMS works across adult patients, it works in the elderly, so whether you're an adult psychiatrist or working with elderly patients, you should just have the knowledge of when and why you should refer, and have enough knowledge to be able to talk to your patients about TMS like you would talk about all the other range of treatments. I kind of almost think that is, well, I actually think that's mandatory now. I don't think a general adult or old age psychiatrist is sufficiently competent if they don't have that basic knowledge, because it's a viable treatment that should be considered in their patients. And the evidence would suggest quite clearly that if somebody's failed two antidepressant medications and they've got a case of depression, I would argue very strongly that TMS should be discussed as an option with a patient at that time. They should be given the choice. It's as good, if not better, than pretty much anything else that you can do at that point in time. Now, it may be inconvenient, it may not be accessible, it may be too expensive, the patient may not want to do it, they might be frightened about this idea of this strange machine, but it should be discussed at that point in time. So I think there's a baseline level of knowledge that all psychiatrists should have. Then if a psychiatrist wants to go to the next step and sort of incorporate it more actively in their practice, there is a bit of a challenging decision around what does that actually look like in terms of what's the model of care. And
before we get into that, I was just wondering if this was a good chance to tell people, maybe inform psychiatrists where they can go to learn more about who to refer. Is there a TMS clinic's website that can kind of discuss the general criteria for a patient that they can refer on, or is it as simple as you failed two antidepressants, time to refer, and you're over the age of 18? Is it just that simple?
It probably is that simple.
Right.
Although there are lots of sources of information on clinics, as well as just general professional literature. And interesting now, some extraordinarily promising data, although it's not regulated yet, suggesting that TMS might be very effective in adolescents with depression down to the age of 12. But that's another story. So I think just having that, and there are also lots of training courses, and this, and I think training courses are available which will train a psychiatrist to be competent in prescribing TMS and providing it in their practice. But I don't think it's I think there'll be lots of psychiatrists who would want to go and do that training, even if they're not doing it personally, because that provides a much more in-depth understanding of a new treatment. If you're a orthopedic surgeon and there's a fundamentally new way of operating on hips that's as effective or more effective than what you're doing, you're probably going to go and do a training course and learn what that means, even if it only means that you're referring to your mate up the road, for the complicated patient who needs that new procedure. So I think, although most of the training courses are oriented towards becoming a TMS practitioner effectively, I think they're also very valuable for somebody who just wants to know more.
Okay, so if I want to know more, I can do the training course. Now I want to start incorporating it into my practice 2 days a week. What's the next steps there?
Yeah, so again, I think it's about deciding what the model is. So, there are some psychiatrists who have a TMS machine in a standalone practice. Gets a little bit complicated because you have to have essentially you have a nurse or somebody actually providing the treatment. And so do you have enough flow through of patients to support that? In one of the clinic programs that I'm involved in, a group called Monash Mental Health Group, we have quite a number of psychiatrists who work with us, and they assess patients for TMS and prescribe the TMS within the clinic around a variety of locations in several states of Australia. But then the infrastructure is provided, and the nursing staff and the allied health staff who provide the treatment and the back end. So we have quite a few psychiatrists who've chosen to join us, as well as having a group of peers. We have a WhatsApp group, so we can talk about all the challenging patients that get referred who might have a stent somewhere in their brain or their heart, or they've had some traumatic brain injury, and we can discuss the brain scan and is this safe or is it not safe. That might be a little bit more challenging if you're just working as a solo practitioner. So I think thinking about that model and how that works is probably as important as anything else. But ultimately it's about getting the training and becoming familiar with the equipment and the indications. And TMS is used now in some other conditions like obsessive compulsive disorder. So what does that mean? How does that fit into your practice? Do you need a different machine, a different coil? So the more education you can get, obviously the better.
So how much would a TMS machine just by itself cost?
Look, they vary. The standard most basic machines are sort of around the $50,000 mark, right. And that is standalone and relatively straightforward to use for basic treatment.
So, Professor Fitzgerald, Paul, thank you very much for having this conversation with me, and I'm very excited to see in the next 20 years all the other brain areas that start getting stimulated, all the other illnesses that start getting Medicare funded. And I hope to have you on again in the future to discuss those. But that was just incredibly insightful and helpful for me, and I hope for many other people. So thank you very much for joining the podcast today.
You're most welcome. It's been a real pleasure.